So we'll just get an idea for a short note as to how the sanctuary sites in chemotherapy work. So by definition we can say that these are anatomical regions or compartment where the chemotherapy drug or the systemic therapy fails to achieve its therapeutic drug concentration due to anatomical or a physiological barrier causing its reduced perfusion. So they are safe places for the tumor to harbor itself, the malignant cells to be away from the chemo drug, and they can grow. They escape the cytotoxic effects of the drug. So we put a flow chart. IV drug given, blood concentration of the drug is adequate, but due to blood-brain barrier, poor drug penetration, there is subtherapeutic drug concentration in the sanctuary site. So what happens? The residual tumor cells or the tumor cells, whatever is there, will survive. There is increased chance of relapse and all that. So causes, why do they exist? Blood tissue barriers, tight endothelial junctions and transporters prevent drug penetration. There are usually, when these barriers are, there are drug efflux pumps. That is number 2, like P glycoprotein, MDR1 receptors, MRP transporters, and this is one of the reasons why there is a blood the barrier there. Then we have poor vascularity, hypoxic regions that can cause reduced drug delivery, and it has a different microenvironment which is immune privileged and which can survive the cytokines and all that. These are the main reasons or physiological causes for sanctuary sites to develop. So the common sanctuary sites: central nervous system. Cause, as we all know, blood-brain barrier. Due to the tight astrocytic food processes and the endothelial junctions with small fenestrations and an active P glycoprotein efflux pump, chemotherapy fails to enter. Especially in cases like acute lymphoblastic leukemia, DLBCL, CNS DLBCL, testicular lymphomas. Testicular can sometimes go and harbor the small cell lung cancer, melanoma. These are some of the common cancers where CNS disease can behave as a sanctuary site. When the chemo drug is given, still it does not go and penetrate. So residual leukemic cells in the CNS can cause CNS relapse. So how to prevent this? We need to give a CNS drug. What is it? Intrathecal methotrexate, cytarabine, hydrocodone. It is given intrathecal drug. High dose triple IT regimen. We give methotrexate, high dose cytarabine, and high risk AL. Sometimes we give cranial irradiation also. So this is something that we need to know. Again, blood testis barrier. Testis is one site. Many chemotherapy agents do not enter into the seminiferous tubules adequately because these are Sertoli cells and the endothelial junctions there form a tight junction there. It is a common sanctuary site for ALL, TALL and lymphomas, testicular lymphomas. So clinically this can present as a testicular enlargement or an isolated relapse in the testis despite the whole marrow being completely in remission, completely responding to the chemo. So that is one site. And then we have eye, ocular sanctuary, blood retinal barrier, blood aqueous barrier. So you have a primary vitreoretinal lymphoma or a leukemia in the retina, that eyeball. So there persistent ocular disease can be there despite giving good chemotherapy. In this case, either we give a orbital RT, ocular RT, or we can give intravitreal drugs. Needs to be given methotrexate. Drugs like that need to be targeted. CSF fluid, again it is related to CNS basically. Most drugs are heavy drugs, hydrophilic. They have high protein binding capacity. Automatically they have poor CSF penetration, also due to the blood-brain barrier. So then intrathecal chemo, again that becomes the major treatment part. Placenta also acts as a partial barrier. In one way it is good, it limits the fetal exposure to several drugs. That is there, that also acts. So we know the mechanisms. Drugs with poor CNS penetration. Poor penetration is adriamycin, paclitaxel, vincristine, vinblastine. They are all poor CNS penetration. Good penetration, high dose methotrexate, temozolomide, carmustine, lomustine, high dose cytarabine, thiotepa. All these are good penetration into blood-brain barrier. So clinical significance is that we know the site of relapse. 1. 2. We need to know in which cases CNS relapse is higher. So this helps. Sanctuary sites helps. It determines the drug selection for blood-brain barrier penetration. It can change the treatment protocol, and sanctuary sites also tell you up to some extent the prognosis of the disease. There is higher burden of CNS relapse, causing worse prognosis if left untreated. The role for RT to the sanctuary sites in certain cases also. You can give a testicular boost or a cranial boost or whole craniospinal irradiation depending on the sanctuary site and its residual disease.